Alrighty, we're going to get going because we have a super tight agenda. I'd like to welcome everybody back to the Best of SWOG Summer of 2022, or Highlights of ASCO. You are going to hear about some of our best work from a variety of committees. I encourage you to put your questions in the chat box, and with no further ado, we'll jump to Dr. Goldkorn, who will tell us about using cell-free DNA to predict bladder chemotherapy benefits.
Thank you, Dr. Blanky. Can you hear me okay?
Perfect.
Okay, great. Well, thank you for the opportunity to present here. I'll try to stay on time. So as Dr. Blanky said, our work was looking at cell-free DNA methylation as a predictive biomarker of response to neoadjuvant chemo for patients with muscle-invasive bladder cancer in SWOG S1314. And this was an oral abstract in the GU session at ASCO Kidney and Bladder. Next. So briefly, the background: cisplatin-based neoadjuvant chemo is the standard of care for patients with muscle-invasive disease. However, it's quite toxic. Only some patients derive benefit. And so there's a lot of work being done trying to identify new biomarkers to predict response. SWOG S1314 was one of the trials looking at identifying such biomarkers. It actually focused on the coxin transcriptomic signature. And what we did was an additional exploratory analysis within that trial. You see the trial design on the right. It's patients with muscle-invasive bladder cancer who are getting one of two standard arms of neoadjuvant chemotherapy, dose-dense MVAC or GemCis, and then going on to the radical cystectomy. We took additional blood at cycle 1, day 1, and cycle 2, day 1 to look at cell-free DNA methylation analysis. Next. So why cell-free DNA methylation? Plasma cell-free DNA and DNA methylation in general yields tissue and tumor-specific epigenetic profiles, signatures, if you will, that can be used for cancer detection or molecular subtyping. In fact, to date, it's been used predominantly for those purposes, for de novo cancer detection or post-treatment detection of MRD, minimal residual disease. Here we asked a different question. We said, can we take the plasma cell-free DNA, the methylation patterns, and predict who will and who will not respond to neoadjuvant chemo from this upfront samples in this study? So we collected from 73 patients where we had the pre-treatment samples, another 57 of them we had on treatment. And can you still hear me okay, hopefully? Yes. Plasma samples were extracted. We did bisulfite conversion and ran them on an Infinium methylation epic B-chip array, which basically looks at methylation sites across over 850,000 sites in the genome. The reason we use this array, this is actually kind of a first in this setting as far as we know. It's cost-effective, commercially available. It was actually initially used in the TCGA studies. These are more advanced next generation versions of these arrays. And it's got a very standardized downstream analysis tools that we could use for the computation. We did a lead-in study that showed that it worked well in cell-free DNA from the plasma. Next. So here are the results. We generated what we called an MR score. If you look on the left there, it's a methylation-based response score that tells you, predicts response to the neoadjuvant chemo, either a complete response, which is pathologic CR at the time of cystectomy, or PR, which is a downstaging, or no response, which means the patient's still at PT2 or higher. And we did this using random forest machine learning, basically generating the best possible methylation patterns that differentiate responders from none. And the ROC curve is shown there with an AUC of about 64%. You could see that the MR score also correlated with the depth of response across response levels, and also worked similarly for both arms of the study for GemCis and also the dose-dense MVAC treated patients. Next. We were gratified to see that we can also apply this after the patient start therapy. So we took the same models from baseline and generated MR scores using the plasma collected after the first cycle of chemo. And you could see the ROC curve on the left, actually a little bit better performance. And on the right there, you see that on treatment performance, the pink bars relative to the blue, the prediction accuracy was as good or even a little bit better. Next. We also used the methylation data to deduce how much circulating bladder DNA was in the blood of these patients. So there have been algorithms published in recent years that allow you to deconvolute how much contribution from each tissue type is in the blood based on the methylation signature. So we were able to calculate how much circulating bladder DNA there was in these patients. And you could see that it correlates on the left there, healthy donors versus patients who had complete response, partial response, and no response. There was a trend towards a correlation there, relatively small cohort, showing that there was greater and greater amounts of circulating bladder DNA. And on the right, we actually looked for any correlation between the circulating bladder DNA and these MR scores, the methylation predictive scores. There was no correlation, which means that these two variables are independent of one another. So based on that, next, we actually generated this proposed risk stratification model using these different variables. So we took 57 patients on the left there that had both the baseline and the on-treatment bloods. We first risk stratified them by the level of their MR methylation score and the amount of circulating bladder DNA in their blood. Patients who were high for both, actually 10 or 12 of those patients that were considered high risk indeed were the non-responders. Conversely, at the bottom, 18 of the 22 deemed low risk indeed were patients who had a response to therapy. And then we risk stratified again based on their on-treatment score to further assign the patients that were remaining. And overall, we were able to assign using these MR scores and the bladder content 45 out of the 57 patients correctly to their response to neoadjuvant chemo, 75% of the patients. Next. So in conclusion, this was a pilot study. It was a proof of concept. We believe that we've shown that this Infinium methylation EPIC B-chip array plus machine learning algorithms, random forest, can be used to generate plasma cell-free DNA methylation signatures that are predictive of response to therapy. It worked to correctly assign our patients in nearly 80% of the cases, and we feel that with further validation, it may help in treatment selection for these types of patients. We think there may be great potential also in more metastatic disease settings where you'll have higher levels of cell-free DNA and circulating tumor DNA, and where tumor is often not available. And it's important to remember that these signatures reflect the total circulating methylome, the cell-free DNA. They're not just derived from the somatic ctDNA component in the blood, and this may end up actually having potential utility when looking at patients treated with other therapies, like, for example, immune checkpoint inhibitors, where you want to maybe look at some of the methylation signatures in the blood that are also coming from leukocytes, et cetera, in the cell-free DNA. Of course, all this will require further validation and additional studies. Next. So just thanking the many people who contributed. Photos there to my left, John Liu, who did this work in my lab. To my right, Tom Flagg, who was the study chair for S1314 and also was kind enough to present this work at ASCO. I wasn't able to attend the meeting in person. And other USC collaborators on the left and our SWOG collaborators on the right, and our patients and funding sources. So thank you very much, and I'll stop there and wait for any questions.
Great. Thank you so much. That was amazing. You already answered one question, which is about the application to other systemic therapies like checkpoint inhibitors. What is going on with other tumors?
Yeah, this approach is being looked at more and more across a variety of tumor types. There are already some small studies that have been reported in gastric cancer, liver cancer. There have been a study reported in Nature Medicine, kidney cancer, also looking at cell-free DNA methylation. They've used various platforms to look at the methylation profiles. They all have their pros and cons. The majority of them have tried to generate a signature that tells you whether there's tumor there or not, like MRD. We could detect tumor or we cannot detect tumor. Super important. That's where a lot of the work is going. What we're proposing here is that in addition, you could also do your learning, your machine learning on whether patients respond or not just whether there's detection of tumor or not. So all those things could be useful applications across a variety of tumors for the plasma methylation profiles.
Lovely. And as a last comment, you want to say what you specifically would like to do in SWOG, if anything?
Always. I'd love to validate this further. We could do it in a similar disease setting, like neoadjuvant chemo for locally advanced disease in bladder, as I alluded to in my slide. I think the same approach could be applied in larger cohorts with metastatic disease as well, and bladder cancer, and as well as other cancers. So we'd love to try this across larger cohorts, validate our cut points, and really hopefully tack this down.
Well, perfect. And thank you so much for being so efficient. We're going to move on to Dr. Kendra, who's going to give us the S1512 trial results. I hope. Dr. Kendra is here, muted perhaps? Can you guys still hear me okay? Yes, okay. Yeah, I definitely see a mute. No mute now. Dr. Kendra?
Yes, can you hear me?
Yep, perfect.
Okay, sorry. Good afternoon, everyone. I'll be presenting the data from our SWOG 1512 study, Neoadjuvant PD-1 blockade in patients with resectable desmoplastic melanoma. This was an oral abstract in the melanoma section. Next slide, please. Desmoplastic melanoma is a rare melanotic tumor found in highly sun-exposed areas. Histologically, as there's spindle cells and a background of abundant collagen is noted by the blue areas on the slides. At diagnosis, is frequently deeply infiltrated and neurotropism is common. Current management is surgical excision plus or minus radiation. There are many challenges with the management of local desmoplastic melanoma. The lesions appear to present as small primaries, only to find histologically that they extend well beyond that seen clinically or in imaging. The presence of perineural invasion can make it difficult to achieve clear margins. And so with that, multiple surgeries or large excisions are frequently required, resulting in large clinical defects in highly visible areas. Next slide. A retrospective study was published in Nature where they looked at collected data from people who received PD-1 and PD-L1 blockade from 10 academic centers. 57 patients were found who carry the diagnosis of advanced desmoplastic melanoma. And in that population, there was a marked response, a complete response rate of about 32%. As you can see by the photographs on the right, the responses were quite dramatic. Just to give you an example of the clinical response seen. Next. So there are some potential advantages to neoadjuvant therapy in locally advanced desmoplastic melanoma. A high response rate in the neoadjuvant setting would have the potential to change the course of therapy for patients with locally advanced disease. If significant tumor regression is noted, the use of radical surgery and radiation may be reduced. Morbidities associated with the surgeries would be decreased, and the result would be a higher quality of life for patients. Our hypothesis thus was locally advanced desmoplastic melanoma with high mutational load resulting from chronic sun damage will have a high response rate to PD-1 blockade, and that pembrolizumab can be administered safely to patients with desmoplastic melanoma in the neoadjuvant setting, resulting in significant tumor regression. Next slide. Our primary objective was a pathological complete response rate, and our secondary objectives were overall response rate, median overall survival, and safety and tolerability in the neoadjuvant setting. Next slide. Our study had a 90% power to detect a pathological complete response rate of 25% with a one-sided alpha of 3.4%. Next slide. Our key eligibility trial was the patients had to have resectable desmoplastic melanoma, and they had to have residual disease after their biopsy. And that residual disease can be confirmed either radiographically, clinically by exam, or if it was non-measurable disease, validated with an FNA. Patients would receive Pembro every 3 weeks for 3 cycles, and if resectable, would proceed with surgery. If there was concern for progression, they could continue with 1 more cycle to confirm progression versus delayed response. Tumor measurements were obtained prior to the first treatment and at 9 weeks. Tissue was collected prior to the first treatment and at the time of surgical resection for correlative analysis. Next slide. 30 eligible patients were enrolled. 1 patient refused treatment and withdrew consent. 29 patients were then treated with pembrolizumab and included in the efficacy and safety analysis. 26 had measurable disease at baseline and was included in the clinical response analysis. 1 patient refused surgery, so 28 patients underwent surgical resection, and this included the 1 patient who discontinued therapy after 1 dose due to immune-mediated colitis, and this patient successfully underwent resection. Next slide. The median age of our patient population was 75. Next slide. And they were predominantly white males. Next slide. The primary site of disease was located in the head and neck area, all consistent with the common characteristics of desmoplastic melanoma. Next slide. 13% of the patients had node-positive disease upon entry in the study, and this was noted radiographically or by clinical examination. Next slide. Patients were required to have resectable disease that could either be at primary diagnosis or with recurrent disease. Of the patients enrolled on the study, 79% were being treated for their primary diagnosis. Next slide. The mean number of cycles received was 3. One had early discontinuation due to colitis after cycle 1, and the median time from cycle 1, day 1 to surgery was 81 days, which was a mean of 11 days after completion of the 3rd cycle of Pembro. 93% of the patients underwent wide excision. Of those, 62% had a sentinel lymph node biopsy, and 10% had a lymph node dissection. The decision of approach was based on standard of care. One patient underwent a resection of the nodal recurrence without wide excision, as this patient had no other evidence of disease. And one patient elected not to proceed with surgery. Next slide. 16 of the 29 patients, or 55% of our patients, demonstrated a pathological complete response, and this was defined as no viable cancer cells detected in the surgical specimen. Of those who had a non-pathological complete response, one patient had residual disease reported as measuring 0.2 millimeters. One patient chose not to undergo resection after a clinical complete response and was considered a non-pathological complete responder per protocol. None of the patients became inoperable. Our study thus successfully met its primary endpoint of achieving a pathological complete response of greater than 25%. Next slide, please. This 55% pathological complete response noted in the desmoplastic melanoma population after treatment with single agent pembrolizumab was higher than that noted in other neoadjuvant studies for other cutaneous melanomas. Next slide. And was comparable to that seen when combination immunotherapy was used, with toxicities being far less with single agent pembro than with the combination immunotherapies. Next slide. Thus, desmoplastic melanoma demonstrates a unique sensitivity to neoadjuvant immunotherapy, giving us that pathological complete response rate. Next slide. Our forest plot demonstrates no difference between these characteristics. Our patient number was small and was not powered to separate out these differences. Next slide. These are examples of the clinical responses seen. The top patient on the left, that was his disease at presentation after 3 cycles. There was no evidence of disease clinically left on the scalp. Surgical resection of that would have left a large defect on his scalp. The second patient below was a lesion on the back, and as you can see, the dramatic response as well being noted on the right. Next slide. Rapid clinical responses were noted. This patient had a lesion on his lower lip. By day 3 after his first treatment, a response was already noted. And by day 4 of his 3rd cycle, there's no clinical evidence of disease. This is the patient that elected not to receive surgical resection.
Thanks. We probably ought to jump to your conclusions just to make sure we stay on time. Thank you.
Sure. You can advance the slide. Advance the slide. There were 3 deaths. Those were not due to toxicity or progression, but due to other comorbid conditions. Next slide. Next slide. Toxicities were consistent. Mutational status was as expected. Next slide. In summary, the study met its primary endpoint with 55% of treated patients achieving a pathological complete response with a neoadjuvant pembro. The observed clinical response rate at 9 weeks was 46%. Median overall survival not reached. Toxicities were generally of a low grade. No patient on trial had surgery canceled due to AEs. No patient on trial became unresectable, and no patients have relapsed. This supports the use of pembrolizumab in patients with locally advanced desmoplastic melanoma early on prior to surgical resection, and in some patients may eliminate the need for surgical resection. Next slide. These are my acknowledgements thank you.
That was great. Not seeing any questions, I will offer one of my own. And you talked about the unique responsiveness of desmoplastic, and I'm sure I should know the answer to this, but I don't. What are
You
the
can
data
skip
for,
that slide.
what are the data for immunotherapy and things like ocular melanoma? And I realize it's not a surgical question, but a metastatic question.
So ocular melanomas, the uveal melanomas, they tend to be less responsive to immunotherapy. Desmoplastic melanoma, because of its UV damage, has a high mutational burden, and with that, the higher response rates. The uveal melanomas, those of the eye, those tend to not be caused by UV damage, and with that, their response rates are lower.
Perfect and great presentation. Thank you so much. With that, we're going to move on to Dr. Scott Ramsey, the chair of our CCD committee. He's going to be telling us about Tracer.
Hi, everybody, and thanks, Chuck. In this presentation, I'll summarize the primary results from the Tracer trial S1415CD that was shown at ASCO 2022 as two poster presentations. Next slide. Primary prophylactic colony stimulating factors, or PPCSF, are prescribed to patients receiving chemotherapy to reduce the risk of developing febrile neutropenia, a serious life-threatening complication. While potentially beneficial, PPCSF treatment is costly and exposes patients to side effects. Prior research suggests poor adherence to PPCSF relative to clinical practice guidelines, with both underuse in high-risk chemotherapy and overuse with low-risk chemotherapy. Of note, there is insufficient evidence to determine the benefits of PPCSF for patients receiving regimens with an intermediate risk for febrile neutropenia. Next slide. Next slide. Thank you. No, back one, please. Accordingly, the objectives of Tracer, a pragmatic, prospective, cluster-randomized trial, was to determine if guideline-informed standing orders improve PPCSF prescribing and reduce the incidence of febrile neutropenia. Tracer's primary outcome was rates of PPCSF use among patients in the intervention versus usual care sites, and in a sub-study of patients receiving intermediate febrile neutropenia risk regimens. The secondary outcome was febrile neutropenia incidence within 6 months of initial therapy. Next slide, please. This slide summarizes the study schema and eligibility. Randomization was at the clinic level. Clinics were eligible if they were a designated NCORP cancer care delivery site. Clinics that had no PPCSF ordering system were randomized 3-to-1 into the intervention, consisting of standing orders and system alerts added to their order system, or usual care. Clinics that had existing PPCSF order systems were enrolled in a parallel cohort study. Among clinics randomized to the intervention arm, there was a secondary randomization for patients receiving intermediate risk chemotherapy, with one group of clinics receiving standing orders to prescribe PPCSF, and another group with an alert not to prescribe PPCSF. In all settings, physicians could override the orders at their discretion. Eligible patients included adults with breast, lung, or colorectal cancer, with plans to receive initial systemic therapy for their disease. Next slide, please. There were 3,605 evaluable patients, 2,989 in the RCT arm, 707 in the cohort arm, slightly above our planned enrollment goal. The mean age was 58.1, 77% were female, 61% of the patients were being treated for breast cancer, 12% for lung cancer, and 27% for colorectal cancer. For the primary outcome of PPCSF use, there was no significant difference in rates of prescribing among persons receiving high-risk and low-risk chemotherapy, with a slight trend towards less adherence in the intervention arm. The adjusted rates of PPCSF prescribing in the trial were similar to that observed in the parallel cohort study. For the secondary outcome, febrile neutropenia rates were 5.7% for intervention and 4.2% for usual care, a non-significant difference. The febrile neutropenia rate was 14.9% among high-risk patients who did not receive PPCSF. Rates of febrile neutropenia among patients receiving low-risk chemotherapy did not differ significantly between study arms. Next slide. For the intermediate risk substudy, among 524 patients enrolled at 36 sites, Rates of PPCSF use were significantly higher among clinics randomized to the PPCSF arm versus the do not prescribe arm, 37.1% versus 9.9% respectively. The febrile neutropenia rate among patients receiving intermediate chemotherapy was low, with no difference between arms, 3.7% in both. Of note, among patients who did not receive PPCSF in either arm, febrile neutropenia rates were similar, 3.8% versus 4.1%. Next slide. In summary, this guideline-informed standing order did not increase PPCSF use for high-risk regimens or decrease use for low-risk regimens. Standing orders did influence PPCSF use among patients receiving intermediate-risk regimens. Guideline adherence across all risk groups exceeded historical rates. Order entry systems did not impact febrile neutropenia rates for any risk group. And for patients receiving intermediate risk chemotherapy, febrile neutropenia rates were substantially lower than expected, as predicted by guidelines, and did not differ between patients that did versus did not receive PPCSF. Next slide. In conclusion, this study suggests that in situations where there is established evidence for PPCSF use, in this case, for high and low risk chemotherapy, automated standing PPCSF orders are neither helpful nor effective. In situations where there is limited evidence, in this case, for patients receiving intermediate risk chemotherapy, automated standing PPCSF orders may be useful to influence prescribing and can generate important evidence to guide future decision-making. Next slide. I'd like to acknowledge my study co-chairs, the biostatisticians, our external advisory group, most notably the patients who were involved, patient advocates who helped design this study, and other contributors. Thank you.
Dr. Ramsey, thank you so much. Understanding that, of course, you go into a trial like this with equipoise, were you surprised by any of the results?
Well, we were quite surprised by the high level of adherence to PPCSF because other studies have shown much poorer adherence, and that certainly was a factor. We were also surprised at the very low rate of febrile neutropenia among patients receiving intermediate risk chemotherapy. It was about a third of what's predicted for that type of chemotherapy in guidelines such as NCCN.
Thanks. And are you or SWOG or anybody going to try to measure uptake of results, at least in the intermediate risk patients? Is there any way to do that?
Uptake of results?
Yeah, I mean, just putting any of this into practice.
Oh, well, we think the finding for intermediate risk is a practice-changing finding, and that patients in general who receive intermediate risk therapy should not be getting colony-stimulating factors. So we do plan, after the primary publication is out, to do a bit of a marketing campaign and to take this directly to the guidelines groups with our findings.
Oh, perfect. Exactly what I wanted to know. Okay, I think that will wrap it up. Thank you again for presenting. We're going to move on to Dr. Karen Reckamp, who's going to be talking about one of our most exciting findings of the year, results from S1800A lung map.
Thank you. So we presented this at the metastatic lung oral session, and this is presenting just the S1800A trial and some future implications. Next slide. This is looking at the overall survival from our phase 2 randomized trial of ramucirumab and pembrolizumab versus standard of care for advanced non-small cell lung cancer patients previously treated with immunotherapy, again on lung map, non-matched study S1800A. Next slide. So we know that acquired resistance to immunotherapy is common. Frontline therapy now for non-small cell lung cancer for patients without activating mutations includes PD-1 or PD-L1 therapy for most patients. And though we have improvements in survival, which has been spectacular for our patients, resistance develops in most, and we need additional therapy for these patients. So this is a major area of unmet need for our patients, and we have a significant interest in developing therapies to overcome this resistance. Next slide. So we also know that angiogenesis-modulating factors have significant modulation factors on the immune system. We know that VEGF is important in direct modulation of tumor immune cells. It can induce PD-L1 on dendritic cells and suppress their maturation, impede T-cell extravasation, and inhibit the cytotoxicity of cytotoxic T lymphocytes, can stimulate proliferation of T regulatory cells, modulate the endothelium. It can also have direct effects on the vasculature and inhibit immune extravasation cells to get into the tumor site. So we have looked at VEGF receptor 2, which ramucirumab is a VEGF receptor 2 antibody. And with Blockade, we can increase the infiltration of mature dendritic cells. And so combining pembrolizumab and ramucirumab may overcome this resistance, reduce the tumor neovascularization, and upregulate pro-inflammatory cytokines and bring more activated T cells into the tumor. Next slide. This is just a schematic. Next slide. And so we also have seen combination VEGF receptor and PD-1, PD-L1 therapy has been demonstrated to show benefit in the clinic, and we have multiple FDA approvals for patients who are immune checkpoint inhibitor naive, renal cell carcinoma, endometrial carcinoma, hepatocellular carcinoma at this time. We know that pembrolizumab as an anti-PD-1 monoclonal antibody has significant number of indications. And again, most patients with non-small cell lung cancer will receive pembrolizumab or another PD-1, PD-L1 inhibitor at some point in their therapy. And ramucirumab is a monoclonal antibody directed against endothelial growth factor receptor 2. We did see primary activity of the safety and the activity of pembrolizumab and ramucirumab in a phase 1 trial. Next slide. This was performed by Dr. Herbst and his team, and this is in patients who were, again, immune checkpoint inhibitor naive. But in these patients who had prior treatment, these patients had a response rate of about 30%, progression-free survival of about nearly 10 months, and a disease control rate of 85%. Next slide. So we performed this study in the LungMap protocol, and this is a public-private partnership, and it's a master protocol specifically looking at patients with stage 4 or recurrent, previously treated non-small cell lung cancer. I think the importance of this is that this protocol, being a platform protocol across many sites, including community sites, has been nimble in its ability to change with the rapidly changing standards of care. The LungMap protocol was designed and started before immunotherapy was approved for non-small cell lung cancer, and again, was able to adapt to include patients who have been treated with immunotherapy as the frontline therapy evolved. Overall, it's had 15 trials, over 4,000 screened patients at least 600 sites, more than 50 publications and abstracts, and over 10,000 specimens are banked. Next slide. This is just the current schema. This changes over time, and we currently have opened the green studies. The blue are in planning. On the left-hand side are the biomarker-driven studies, and at any given time, we have a non-match sub-study open on the right-hand side. It did open to patients with all histologies in 2019. Previous to that, it was specifically for squamous cell histologies. Next slide. So in our S1800A study, we looked at patients who were not eligible for a biomarker match sub-study. We were looking for 130 eligible patients in the randomized phase 2 trial with a primary endpoint of overall survival, which is important, as you'll see, and recommended by our biostatistical team led by Mary Redman. Our primary analysis was a one-sided 10% alpha, and we were looking at testing at the better of the standard log rank and weighted log rank test to better understand and see the delayed effects that we thought we might see with immunotherapy-based therapy. Next slide. Here's our schema. Patients were stratified by PD-L1 expression, histology, squamous or non-squamous, and the intent to receive ramucirumab in the standard of care arm. I think importantly, so patients in the experimental arm, arm B, received pembrolizumab and ramucirumab. In arm A, it was an investigator's choice standard of care, which included docetaxel and ramucirumab, but could also include single agent chemotherapy. Our primary endpoint, overall survival, and again, the key eligibility was that patients had to have received prior PD-1 or PD-L1 inhibitor therapy and have progression at least 84 days after the initiation. And they had to have progressed on platinum-based doublet, either in combination or sequentially. And ECOG performance status 0 to 1. Next slide. Our patient characteristics are seen here. Just of note, we did have slightly higher ECOG performance status of 1 in the standard of care arm. PD-L1 was less than 1 more frequently in the ramucirumab pembrolizumab arm, and greater than 50% more frequently in the standard of care arm. Next slide. Here we see the overall survival. So we have a significant improvement in median overall survival and overall survival from the start of the therapy. 14.5 months versus 11.6 months in standard of care with a hazard ratio of 0.69 and the standard log rank p-value of 0.05. Importantly, as you see below, the majority of patients, 2/3 of the patients, received docetaxel and ramucirumab, which is considered the most active. It had increased response rates, progression-free, and overall survival over single-agent docetaxel. So importantly, most patients received the most active therapy. Next slide. Looking at subgroup analysis for patients with overall survival, overall, there is a trend toward benefit for all subgroups. I think that's the most important thing. We did not see any significant benefits based on PD-L1 status. There was a more pronounced benefit for patients with squamous cell or mixed histology. And we did see patients have a more prominent benefit for those who received chemo followed by IO therapy. Performance status was not affected by treatment, and so still had benefit in performance status 0 and 1. And we did see some benefit in patients with STK11, but there were no biomarker co-mutations that really stood out as significantly changing outcomes to treatment. Next slide. So progression-free survival was not different between both groups, but we do see kind of a prolonged tail here, and we do see the trend toward benefit in all of the groups, but again, not significantly different. And this has been seen in previous trials utilizing immune checkpoint inhibitor therapy in subsequent lines of therapy. Next slide. Again, response rate not significantly different, but duration of response was longer in the pembrolizumab ramucirumab arm at 12.9 months versus 5.6 months. Next slide. The safety was first presented at ASCO 2021. We presented grade 3 to 5 AEs here, and again, more significant number of grade 3 to 5 AEs in the chemotherapy arm. 42% on the ramucirumab pembrolizumab and 60% on standard of care. About 30% had grade 3 to 5 immune-related AEs on ramucirumab pembrolizumab. And we did look at vascular events, which were higher on ramucirumab pembrolizumab. Last year, when we presented the safety data, when we pulled out the vascular events, they were similar for all patients who received ramucirumab. Next slide. So overall, some limitations, just the randomized phase 2 design means that the numbers are smaller and we have limited interpretation of our subgroups. We do have some heterogeneity in the prior immune checkpoint inhibitor containing regimens, which is really reflecting real world treatments and the timing, because things changed over time with the patients who enrolled on the trial. We did adjust for performance status 0 versus 1 and did not see a change in the magnitude of the hazard ratio. So the overall treatment effect was robust in both performance status 0 and 1. And I think importantly for the LungMap trial, this is not completely unselected. So S1800A did exclude some patients who were qualifying for who had qualifying genomic alterations for other LungMap substudies that were open at certain periods of time during enrollment. So included BRCA, loss of heterozygosity, and STK11. Though we did have STK11 in our study because it was only overlapping for a short period of time. The NGS and PD-L1 expression based on the trial is archival tissue. So we have the data ready and patients are ready to enroll, but it's not based on current progression tissue. Next slide. And so we did see an improvement in overall survival with ramucirumab and pembrolizumab over our best supportive standard of care regimens. We did see the discordance with overall response rate and progression-free survival, but this has been seen in prior studies and coined by Dr. Dandera as post-progression prolongation of survival. This is the first immune checkpoint inhibitor refractory setting without a chemotherapy backbone to really demonstrate an overall survival benefit, and especially using docetaxel ramucirumab as the main standard of care arm, as most trials are now comparing these regimens to docetaxel alone. So we expect to evaluate this further in a phase 3 trial and are planning this at this time. Next slide. And we couldn't do this without the Lung Map collaboration. You see the groups involved in helping this to make this possible, and the patients who are willing to participate and help move therapies forward. Next slide. And again, our acknowledgements. Happy to take any questions.
Actually, we're nearing the end anyway. I want to thank you for these truly outstanding results, and you, I believe, already answered probably the most likely question, which is, are we ready to go with this, or should we do a phase 3 trial? So thank you so much for that presentation.
Thank
We're
you.
going to move on to Dr. Ryan, one of our executive officers. He's going to be giving us the results of Everest.
Great. Thank you, Dr. Blanke. Very happy to present the long-awaited results of SWOG S0931, the Everest trial. This was an oral presentation at the kidney bladder GU session at ASCO. It's a culmination of 13 years here of work on an adjuvant trial. At the time this trial was designed in 2009, we were kind of at the end of the first wave of new approved therapies for metastatic renal carcinoma. First tyrosine kinase inhibitors, and then mTOR inhibitors, and everolimus is an mTOR inhibitor. And subsequently, we've had approval of multiple checkpoint immunotherapies for advanced kidney cancer. At the time this trial was designed, there was no known effective adjuvant therapy after surgery, and this remains the first and the only trial examining adjuvant mTOR therapy. Next slide. So, next slide, please. We looked at patients within 12 weeks of nephrectomy who were considered at high risk for recurrence of their renal cell carcinoma. This actually spanned a relatively wide range of stages, everything from T1B high-grade tumors, these are greater than 4 centimeter tumors limited to the kidney, all the way up through node-positive disease that had been completely resected. And patients were stratified based on two groups we called intermediate high and the very high risk group, which were T3A tumors, those growing into the renal vein or breaking out of the kidney that were high grade all the way up through node positive disease. We included both clear cell, the most common histology, as well as non-clear cell. And this is one of the few adjuvant trials that included non-clear cell patients. And it was an adjuvant trial, so patients had no evidence of metastatic disease. They were randomized 1-to-1 to either 54 weeks of daily everolimus 10 milligrams or to a matching placebo. Next slide. The primary endpoint of our trial was recurrence-free survival, and defined as time from randomization to first evidence of recurrent disease or death due to any cause. Next slide. So the trial underwent several statistical permutations during its life. We started enrollment in 2011. In 2015, the Data Safety Monitoring Committee had concerns that there was kind of an excessive number of treatment discontinuations. And for that reason, the sample size was increased. As you can see by looking how the patients were distributed, those discontinuations predominantly occurred on the everolimus arm, where only 45% of patients completed the 54 weeks of therapy, as opposed to 69% who completed therapy with placebo. There was another change to the study plan in 2000 when it was realized that the number of events that were occurring, recurrence events, were not as high as anticipated. They just were not happening as much as we expected. So for that reason, essentially the design was changed to draw a line in the sand And in March of this year, the final analysis was done with 556 of the 804 expected events having occurred with a median follow-up of 6.3 years. So you can see more patients discontinued everolimus, mostly due to adverse events. There was also more dose reductions on the everolimus arm, and the median time on treatment in the end was 9.3 months with everolimus and 12.6 months with placebo. Next slide. Patient characteristics were well balanced between both arms. This was a middle-aged, predominantly male population, as it would be expected. You can look at the racial breakdown. This is actually in line with what we had planned in the trial, but the number of African-American subjects is lower than a current estimation, so that's something we need to continue to work on within the group. Next slide, the breakdown in terms of very high versus intermediate high risk group. 55% of patients belong to the very high risk group, and the majority of patients, as expected, had clear cell histology, but a good representation of non-clear cell histology as well. Next slide. Adverse events were certainly more common on the everolimus arm. Next. 46% of patients randomized to everolimus had a grade 3 or higher adverse event, as compared to 11% of patients on the placebo arm. That being said, the adverse events that occurred were well-known and expected side effects of everolimus. The most predominant grade 3 or higher adverse event, next slide, was mucositis, occurring in 14% of patients with everolimus. Next. Pneumonitis occurred in 13% of patients on everolimus, but was grade 3 or higher only in 1%. And next, the other known side effects, the metabolic side effects of mTOR inhibitors, including hyperlipidemia and hyperglycemia, were also noted, as well as more anemia on the everolimus arm versus placebo. Next. The primary endpoint is shown here, which was recurrence-free survival again. And as you can see, there was an improvement in recurrence-free survival in those patients who received everolimus after surgery. The curve separated early and remained separated during the duration of follow-up, with a hazard ratio of 0.85 favoring everolimus. The one-sided p-value, however, was 0.025, and the pre-specified boundary for significance had been set at 0.022, which had taken into account of 4 interim analyses that we had conducted. So the overall study population narrowly missed statistical significance. Next slide. Patients were stratified by risk group. And again, the very high risk patients shown in the left are T3A high-grade tumors through node-positive tumors, patients with those stages of disease. And as you can see in this group, there was significant separation of the curves with a hazard ratio of 0.79 favoring everolimus in this population, with a p-value of 0.011. The intermediate high-risk group, these are T1B high-grade tumors through T3A low-grade tumors, no difference in recurrence-free survival. And this kind of echoes what has been seen now. There have been multiple adjuvant trials conducted since the availability of new agents. Most of these trials have been negative. 2 trials, one of sunitinib, one of pembrolizumab, reported last year, have shown recurrence-free survival benefit. Both those studies focused the population really on this very similar, very high-risk population. Next slide. So in conclusion, we saw adjuvant everolimus improved recurrence-free survival after nephrectomy, but the significance level was narrowly missed. And the effect of everolimus was especially pronounced and seemed to be really isolated to patients with very high-risk disease, which are the current focus of adjuvant recommendations. Adverse events were consistent with the safety profile of everolimus, but there was a high discontinuation rate in this population, really kind of speaking, I think, to the acceptance of side effects, especially with oral cancer therapies in the adjuvant setting in particular. And we find the results of Everest compelling and warranting further investigation into the role of everolimus and mTOR inhibitors in the current adjuvant landscape. So I especially want to thank everyone who participated in this trial. It was a huge effort and very exciting results. So thank you.
Thanks, Dr. Ryan. So we'll just do one quick one. Narrow misses are so frustrating, but what should the practitioner really take away, especially in regard to this drug in this era with our current repertoire of systemic agents?
Yeah, well, we have FDA approval of sunitinib, which was there was never much uptake of that, and now pembrolizumab, and of course the immunotherapy bandwagon is very attractive. But I would look outside the box. Patients potentially who cannot get checkpoint immunotherapy. We're also going to look more into the non-clear cell population, as this study included non-clear cell, and those other studies did not. And so just keep an open mind to do this. There's something going on here. And certainly the very high risk population are those patients we need to consider adjuvant therapy for, the exclusion of patients with lower risk.
Great and useful answer. Thank you so much. Our final speaker today will be Dr. Joe Unger from the Stats Center. He's going to be talking about Medicaid expansion and clinical trial participation.
Thank you, Dr. Blanke, and on behalf of my SWOG colleagues, I will present our paper titled The Medicaid Expansion of the Affordable Care Act and Participation of Patients with Medicaid in Cancer Clinical Trials. This was an oral abstract at the Health Services Research Session. Next slide. The Affordable Care Act, or the ACA, Medicaid expansion resulted in increased use of Medicaid insurance nationwide. However, the impact of the ACA Medicaid expansion on access to clinical trials has not been examined. So our aim was to estimate the difference between actual enrollment of patients using Medicaid to the expected rate had the ACA Medicaid expansion not been implemented, and determine if there was a difference. Next slide. We examined the number and proportion of patients insured by Medicaid at enrollment over time using data from SWOG. We limited our sample to patients 18 to 64 years old, enrolled in treatment trials between 1992, when SWOG began collecting method of payment data systematically, and February of 2020, just prior to the onset of the pandemic, since after that was considered not representative of past trends, that is data that were observed during the pandemic. To emphasize the comparison between the use of Medicaid insurance to private insurance, we excluded patients with no insurance and military or VA insurance. Next slide. We used an interrupted time series analysis with segmented binomial logistic regression. The implementation of the ACA Medicaid expansion beginning in 2014 was considered the independent exposure variable. And importantly, to account for secular trends in Medicaid use related to economic conditions, we adjusted for the monthly unemployment rate using data from the Bureau of Labor Statistics. Next slide. Here were the results. We examined more than 50,000 patients, less than 65 years old, 2/3 of whom were female, 8.4% were Black, and 6 out of 10 were from states who adopted the ACA Medicaid expansion in the years 2014 and 2015. Next slide. So I'm going to take some time to walk through the time series analysis, because it's important to understand how to conceive of the findings in terms of what we observed happening in the presence of the ACA Medicaid expansion, or otherwise referred to as the factual or actual scenario, compared to what our models suggest would have happened had the ACA Medicaid expansion not been implemented, or the counterfactual scenario. Overall, the proportion of patients with Medicaid increased from 8.6% in the pre-ACA Medicaid expansion period to 11.8% in the post-expansion period. Our analysis is premised on the idea that the proportion of patients using Medicaid for their medical insurance generally will parallel national economic trends, especially the unemployment rate, which is shown in the bottom graph in red. Next slide. So more specifically, you can see how the use of Medicaid insurance among trial participants waxes as the unemployment rate increases and then wanes as the unemployment rate decreases, as shown here in this slide. Next slide. In fact, these trends are highlighted during recessions, including the recession of 1990-1991, the dot-com bubble of 2000 to 2003, the Great Recession of 2007 to 2009, and the onset of the COVID-19 pandemic. And as it turns out, the relationship between the peaks and nadirs of Medicaid use and the unemployment rate follows a very consistent pattern. The average time lag between the peak or nadir of the unemployment rate in the US and the corresponding peak or nadir, respectively, of Medicaid use in trials is about 1 year. Next slide. However, this pattern changed substantially in conjunction with the implementation of the ACA Medicaid expansion. 32 states enacted the expansion between 2014 and 2015, and again, these states comprised more than 6 out of 10 of the US population. Next slide. And whereas in all prior periods, the peak or nadir of Medicaid use in trials followed the corresponding peak or nadir of the US unemployment rate by about 1 year, after the Medicaid expansion, this pattern actually reversed, and the nadir of Medicaid use preceded the nadir of the US unemployment rate by 40 months, or 3.4 years. Next slide. And accounting for these expected patterns in our model, the proportion of patients using Medicaid for their insurance for trial participation in the red, the actual proportion, was much greater than the expected proportion in the light orange had the ACA Medicaid expansion not occurred. So you can see that separation that occurs in conjunction with our exposure variable. Next slide. Overall, we observed a 19% increase per year in the odds of trial patients using Medicaid following the ACA Medicaid expansion. In fact, our model suggested that at the end of the study period, we would have expected 6.9% of trial patients to have had Medicaid insurance at enrollment, since at that time, national unemployment rate was quite low, 3.5%. But in contrast, the actual rate was 17.8%. That's what we observed. Using a different metric, we enrolled 970 patients with Medicaid insurance after the implementation, but we would have only enrolled about 640 had prior patterns persisted. And that represents a 52% increase. I would add that increases in the proportion of patients using Medicaid were much greater among states that adopted the ACA Medicaid expansion compared to those that did not, which is analogous to a dose response finding. Next slide. So in conclusion, the ACA Medicaid expansion was associated with a nearly 3 times increase in the proportion of patients using Medicaid in trials by 2020. This puts representation of Medicaid insured patients among those less than 65 years more in line with expected rates in the US population, which are estimated at about 17.6% based on 2020 data. Next slide. I think these findings are important because improved access to clinical trials for Medicaid patients provides greater access to the newest treatments and trials for socioeconomically vulnerable patients. It's also critical for improving confidence that trial findings apply to all patients. And I think one might reasonably assume from these findings that the recently enacted Cancer Treatment Act, which mandates that state-level Medicaid programs cover the routine care costs of clinical trials for Medicaid patients, may continue to improve access to clinical trials for socioeconomically underserved populations. I'd just like to recognize funding, especially by the American Cancer Society, SWOG, Core Grant, and the Hope Foundation. Thank you.
Thanks, Joe. While everybody else is gathering their comments, obviously many more use Medicaid because of the expansion. Can you say, or can we analyze whether more patients participated in clinical trials overall because of this?
Yes, and that's that other statistic that I referenced. We observed 970 patients with Medicaid use during the time after the Medicaid expansion. And our model suggests we would have only had about 640 without it. So about a 300 patient increase over those 6 or so years.
Thank you. Clear the way you explained it. And you presented a number of important findings on your last slide. What do you think is the most important argument to make to government? What should we be advocating for?
Well, you know, in some ways, this, you know, this study was planned in anticipation of the of advocacy for the Cancer Treatment Act, which ended up being adopted. So I think between this and other studies we've done, it's not just about having, you know, access to Medicaid insurance at enrollment. It's actually also about having good access to continued good insurance, whether that be through Medicaid or otherwise, during the course of treatment and in your survivorship. In your survivorship period. So that's what I would advocate for as well going forward.
Great. Well, thank you so much for your presentation. I think we've seen from everybody's presentation today that even during a pandemic, our work remains very relevant to our patients. I want to thank the presenters. I want to thank all the attendees, and I hope we'll see you again soon. Take care.